Bienvenidos todos los participantes a este
Welcome to all
educativo IAS,
participants to this symposium of the IAS organized together with the AP's 2021 Congress under the motto of the pandemic era's HIV response in Latin America and the Caribbean. We have worked in close contact with GAESCO centers in Haiti. For our region, it's really important to hold this hybrid symposium for the Americas and especially get closer links in the Caribbean region. The goal of this symposium is to discuss the main challenges and updates regarding the response to HIV in Latin America and the Caribbean during the COVID-19 pandemic. During this meeting, we will talk about three main issues: COVID-19, from COVID-19 to HIV, working for a post-pandemic future, the fight against co-infections, HIV and TB, and let's focus on what is important, key populations and the next generation. Today, in the first session, we will mainly talk about the impact of the COVID-19 pandemic on the dynamics of the HIV epidemic in Latin America and the Caribbean. And for this, we have invited several professionals from the region to share their presentations on these issues. After their presentations, you, the audience, will have the chance to ask questions to our panelists. We hope that this agenda will be valuable for you in your current positions. I would like to introduce Dr. Pap, Director of GAESCO Centers in Haiti, who will be a co-facilitator. Dr. Pap, the floor is yours.
Thank you, Monica. Good morning to all. This session, entitled HIV to COVID-19, Working Towards a Post-Pandemic World, is obviously very hopeful. That's a hopeful title as the world navigates to the COVID pandemic with variants being more virulent than the previous ones and the majority of the world not vaccinated, which is the only hope for slowing down this pandemic. The Pan American Health Organization put out some data on the impact of COVID-19 on HIV services in Latin America and the Caribbean. They surveyed 28 countries. 50% reported an impact on COVID-19 on HIV services. This occurred mostly during the first semester of 2020. The good news is that most countries' programs have recovered. Now we have 5 panelists who are quite experienced, will present data from their country and the region on the impact of COVID on HIV/AIDS programs.
Ahora quiero compartir algunas reglas para la
Now,
transmisión.
I'd like to share some information about live sessions. Now you're all muted. Bear in mind that translation into English, Spanish, and French will be available to those of you who are online. Please select your language to hear the presentation and discussions in your preferred language. To those of you who are with us here in the Dominican Republic, the sessions will be in Spanish. I'd like to invite all of you who are connected virtually to please introduce yourselves by typing in the chat interactive box that is right underneath the screen, and you'll see that your message shows in the box to the right of the screen. Please type your name, last name, the organization you work for, and the country you are from. Let's take advantage of this opportunity to connect and get to know each other. Use the same chat box during the question and answer time that will take place right after the presentations. You're also welcome to write comments in the chat box. We would also like to thank Vive Healthcare, Merck, Sharp and Dom, and Gilead Sciences for their support to organize this virtual meeting and for making it possible. Now, I'd like to talk about our membership offering. As an active participant of the IAS Educational Fund for Latin America and the Caribbean, you have the opportunity to receive a one-year IAS membership at no extra cost to you. The membership will be activated once you fill in the post-symposium survey and you tick a box in the survey requesting this membership. If you're already an IAS member, then the existing membership will be extended 1 year. Please know that this symposium is CME accredited. So to find out more about how you can receive your CME certificate, please get in touch with IAS EDU at iassociety.org. I am pleased now to introduce our speakers for today's first session. Our first speaker today is Dr. Omar Sued, who was the director of the research department of Fundación Huésped from 2012 to 2021. Fundación Huésped is a non-for-profit research institute with over 150 staff devoted to combining clinical, social, and translational research, as well as advocacy and clinical and public health services on infectious diseases, HIV, and sexual and reproductive health, with a focus on innovations in HIV care, ARV optimization, dual therapy, and transgender health. He was the president of the Infectious Diseases Argentina Society from 2019 to 2021. He was also the treasurer of that same organization between 2015 and 2018. He was also the chair of the National Infectious Disease Congress in 2021. He was part of the Presidential Experts Committee for COVID-19 response in Argentina until his designation as HIV treatment and care advisor for the Americas at the WHO Regional Office for the Americas, Pan American Health Organization. And this happened now in June 2021. Dr. Sued will present the latest updates on HIV prevention, treatment, and care in Latin America and the Caribbean. Dr. Sued, the floor is yours.
Buenos días. Este año
This year, we commemorate the 4th anniversary of the first description of HIV, which quickly became one of the most devastating pandemics of the 20th century, which had a direct impact on the way we relate to one another. Fear, discrimination were the first reaction. Denial, misinformation, conspiracy theories were also present during this pandemic. The discovery of sexual transmission fostered the use of condoms, which brought down significantly all sexually transmitted diseases, and condoms became like masks, widespread use. Some years later, the etiologic agent was discovered. It took us 15 years to find a treatment which is changing the life of people. We must say that the mode undetectable equals untransmittable carries the message that it's important to start the treatment early so that people may have a long life with good quality. And we need to put an end to discrimination because of the fear of transmission of HIV. At each Congress, we still find with an cautious optimism the new breakthroughs in vaccines, and we still expect and hope to find a cure. The breakthroughs in HIV have been slow if we compare them to what has happened with the COVID pandemic, where we already have an effective vaccine. But it's important that today we have the tools that would enable us to do away with HIV as a public health issue. If we were able to unlock the obstacles we find, we must say that the only reason for which HIV is still a pandemic is because of this gap, which is becoming wider between what we know, between the interventions we may carry out, and the possibility of implementing them. In Latin America, we are also seeing this. We used to be leaders with the beginning of the national treatment programs in the early 90s. Today, the current figures are more concerning. Worldwide, the number of HIV cases has dropped by 23% as compared to 2010. However, in Latin America, the number of cases has increased by 21%. The number of HIV-associated TB deaths has increased by 7%. The HIV death figures dropped only 8%, while worldwide the drop was 39%. We must go back to concentrate on what is important. In most of the countries, the epidemic is still concentrated in key populations. Last year, 44% of the new HIV infections occurred in MSM. The epidemic has spread throughout the countries. However, 55% of the death toll still takes place in large cities. Besides, prevalence among MSM and transgender women is also higher there in cities, and it's there locally in the cities where we have to concentrate our efforts. Vertical transmission is still a pending issue. Cuba was the first country in the world to eliminate mother-to-child transmission, but very little has been done in this respect in other countries. Today, vertical transmission rates in Latin America is 15%, and acceptable if we think of the region's history in maternal health, prenatal care, and antiretroviral treatments. Besides, we have the issue of migrations. Mesoamerica has always been associated with higher vulnerability, higher risk of transmission, but today we have to consider the Venezuelan crisis with over 5 million displaced people, many of them living with HIV, who had to flee the country. Of course, there are several programs to support them with the support of WHO, and the Global Fund made it possible to keep on offering treatments to many patients in Venezuela. But in this context, and considering the pandemic we are facing, the new pandemic, we have to try and identify the opportunities to eliminate HIV as a public health issue. And that's why we have to focus specifically in prevention, early start of optimized treatment. When we talk about testing, we talk about home-used tests. HIV people should know about their status whenever and however they want to. In the case of pregnancy, well, we have used home pregnancy tests. They were patented in 1965, but in 13 years, it took 13 years for them to be widely used because there were some obstacles. Companies mentioned the risks this posed for people, and the labs thought that the test should be done by laboratory technicians. But today, over 80% of the women use these home pregnancy tests, and there are not big issues. The same should happen for HIV. Home tests should be available. The number of tests should increase tenfold so as to get to the figures of countries that have achieved elimination. There are other ways of doing testing with limited investments, these focused efforts, that is testing sexual partners. This has been accepted in Mexico to recover almost 28% of contacts, or testing in people's homes or in areas of sex work. so as to reach people who have never had a test done. This approach helps people, as I have already said, who have never been tested before. When people are tested and turn out to be negative, it's key to refer them to prevention services. In the case of prevention, we have to add PrEP. Brazil, Argentina, Peru, and Mexico have worked hard in PrEP with large international networks, but there are only 20,000 people receiving PrEP on a continuous basis, mostly in Brazil. So it's important to increase knowledge, demand, and advocacy of key populations. And it's also key that healthcare providers analyze the barriers, the prejudice we have to support these populations. A positive HIV test means a person has to start treatment immediately, a treatment that should be safe and effective. And today, this can be done with integrase inhibitors. In Brazil, transitions to dolutegravir made it possible to have treatments that are 42% more effective in viral load suppression than previous treatments with efavirenz. WHO provides access to over 15 countries to once daily tablets of integrase inhibitors at a cost of $5 a month. The use of these treatments in Venezuela has made it possible to optimize over 85% of the population, so they are now taking just one single tablet a day. And the efficacy analysis shows that over 97% of the patients have achieved viral load suppression. If we implemented just these 3 interventions, we might cut down the number of new HIV cases by 75% in a few years. For this, we need a community involvement, formal and direct involvement of MSM and transgender women organizations to help us plan, promote, communicate, supply, and implement these interventions. That's why we need this strong commitment. We need energy and resources to carry out these interventions, but we also need the demands, the requirements of all these people who should call for their rights to be protected for us to eliminate HIV during the COVID-19 pandemic and after this pandemic, because this is up to all of us. Thank you very much. Greetings to you all, and I hope we will be able to achieve this. When? Well, this is up to us.
Muchas gracias, Omar.
Thank you very much, Omar.
Unos segundos, por favor. Vamos a continuar con el
Just a
programa.
few seconds, please. We're going to continue with the program. I would now like to introduce our next speaker. It's really my pleasure to introduce Dr. Marie Deschamps. Dr. Marie Deschamps is the Deputy Director and Co-founder of Gescio Centers. She works at the Gescio Center.
Disculpen que tengo un problema aquí con la conexión.
I apologize, I'm having some audio issues, some connection issues.
Disculpen, vamos a continuar.
I'm sorry for that. She's the head of the Women Health Program and operational manager of the research unit CTU at Guesquio. She's a graduate of the University of Haiti. 1971, she got her postgraduate training in infectious diseases at the NIAID and at the Center for Diseases Control. She has authored many peer-reviewed publications on clinical and interventional studies on HIV and its co-infections. Her research has focused on women's health issues and on HIV/AIDS in Haitian women, including risk factors for heterosexual transmission, HIV prevention programs for women, and ART strategies for pregnant women to prevent HIV transmission from mothers to infants. Dr. Deschamps has received numerous honors for her contributions to AIDS care and research, including the Legion of Merit from President Chirac in 2004. Le Haiti Trésor National Vivant in 2008, the Gates Award for Global Health in 2010. And she will now be talking about the provision of care in Haiti, ideal combinations to deliver health interventions. Dr. Deschamps, welcome. The floor is yours.
Good morning. I have the opportunity to share with you today the ideal combinations to deliver health interventions in the COVID era and targeting mainly the provision of care in Haiti. As you are aware, Guesquio is a non-governmental organization and health institution which has been working in close collaboration with the Ministry of Health, and we have developed a model of integrated and comprehensive approach, model of services to facilitate and contribute to the reduction, prevention, care and services, offer care and services to the population, targeting mainly the vulnerable and those who are at high risk. The port of entry of our services are HIV and TB and other related infections, but for the last 30 years, 3 decades, we have introduced progressively other services to facilitate the beneficiary of our services, including reproductive health service, nutrition unit, care for those who are HIV infected, cardiovascular disease, and the global health unit. The global health is focusing mainly on community services, the PrEP, gender-based violence, social activities, social support, WASH, primary and vocational school, and microcredit. All the services are integrated into one campus. When COVID arrived in 2020, Guesquio had to maintain the services while offering the services to our community to prevent, to diagnose COVID-19. This slide shows a very interesting data. You can see on the left up here, the curve showing when the epidemic started in Haiti in March and had a peak in June. That was the first wave, and the second wave in January 21, and the last wave that we are observing actually in June, July. But the second slide shows exactly what we had observed at Guesquio ourselves. That is, the first one showed the national data. The second slide is showing the data at Guesquio itself, which is the main center for HIV/TB. That is, we attract also the vulnerable people who would arrive to us for services in the context of COVID. So what we have done at GESCIO, we conduct an analysis retrospectively to assess the impact of the epidemic on access to the health services offered at our site and how GESCIO responds to provide continuum of care to our patients. So what was our strategy? To maintain and train our staff, first of all, to make sure they understood that we were dealing with a pandemic, a new epidemic, and we reinforced the patient tracking and community drug distribution were developed, where field workers will go at their home to offer the drugs, knowing that we targeted HIV infected and patients with TB. We initiate COVID surveillance in all our services and at our both sites, GESCIO downtown Port-au-Prince and the one in the north of the metropolitan area, and also conduct with the Ministry of Health along the border, Dominican Republic border at Malpass and Waname. We reinforce the community mobilization and sensitization on COVID, and we reinforce also our lab capacity, introducing new tests for COVID surveillance, and put in place 2 50-bed units in our both sites. What this slide shows is the impact of COVID-19 on our GESCIO services. You can see the epidemic started in March, as you can see in Haiti. However, we observed a sudden decrease of those who are coming for services in April, June, those who are coming for tested for HIV, those who came to receive their treatment or triple drugs therapy, and also those who would arrive for viral load. The same thing was regarding the unit agenda-based violence. We saw a decrease during that time of April and June, where we see because of the confinement measure declared by the state to prevent people to get contaminated. So we could see the impact on our different services. Same impact at national level was reported by the Ministry of Health regarding PMTCT and also infant tested by PCR, infant exposed to HIV. Same findings as well for malaria, as well for TB, and same findings of decrease of services around May, June for antenatal services. Same finding as well for those coming to receive their drugs at new enrollment. However, we can say that the epidemic did not have an impact, a negative impact on our WHO goal 95-95, that is knowledge of HIV status, coverage for ART and viral load. However, we looked at the data at GESCIO, looking at the 471 patients with HIV co-infected. We were looking for the co-infections for COVID. So 22% were also co-infected with COVID, but we saw there were no negative impact on the natural history on looking at retention, loss to follow-up, or death. And recently, in June, GESCIO was the first site in Haiti where vaccination against COVID was introduced at all both sites, and now it is a national program since July. In conclusion, from day one, our institutions set up a surveillance program to monitor the evolution of COVID pandemic in Haiti, set up 2 care centers, and develop guidelines and train more than 2,000 healthcare personnel while maintaining a continuum of services for HIV, AIDS, and other diseases. COVID-19 impacted access to health service at GESCIO and also in Haiti for a short period of time, mainly during the confinement period. With a lot of effort from local and international partners, Haiti responded rapidly to the COVID-19 epidemic, but it did not affect the natural history of HIV infection. Survival and retention were similar in both groups, those who are co-infected with COVID and those who are not infected. Thank you.
Muchísimas gracias, doctora Deschamps.
Thank you very much, Dr. Deschamps. And now we will give the floor to Dr. Samantha Nichols Spencer. Dr. Spencer is a diplomat, the head of the American Board of Internal Medicine, and a member of the Department of the hospital in Jamaica. She will present today about COVID-19 and HIV in the English-speaking countries in Latin America and the Caribbean. Dr. Samantha Nicholson Spence, the floor is yours.
Okay, let's look at the effect of COVID-19 on HIV and other health programs locally. I'm Samantha Nicholson Spence. I'm the head of the Department of Medicine at Kingston Public Hospital in Jamaica, which is the largest multidisciplinary hospital in the country. Now, there was initial apprehension about the vulnerability of persons living with HIV to COVID-19 and severe and critical disease. It was, as the disease was new, COVID-19 that is, there was a low threshold for isolation of persons with respiratory or gastrointestinal symptoms, and it seemed the threshold was even lower for persons living with HIV. Many would get repeatedly isolated to the isolation wards, sometimes for multiple admissions for rule out COVID-19 because they would present with cough, fever, shortness of breath, diarrhea. As we know, these are very common presentations of persons living with HIV to an emergency room. Now, when I reviewed our data, we did an initial analysis looking at our experience at our hospital, looking at data from March to October 2020. During this period, we isolated 708 patients for severe acute respiratory illnesses, or SARI. 217 of these patients tested positive for COVID-19. The area in purple here on the pie chart represents those persons whose results we never received. Now, when we looked at our patients and narrowed it down to the visible spike in patients which occurred between August and October of 2020, now when we look at it and broke it down for the various comorbidities, we found that HIV really did not have a strong representation. When the point of this study was looking at the characteristics of death versus survivors to try and predict which patients were more likely to die. And so it was interesting, it was predetermined that HIV would be one of the components we would be looking at to determine if it predicted mortality. It was not statistically significant, as you can see, but this may likely be due to the fact that there were low numbers. There were only 6 patients during that period that were actually HIV positive, and this is out of a cohort of just over 100 patients. Now, in another ongoing analysis, we're looking at the effect of turmeric on the mortality and course of COVID-19 disease. Again, this study is not specific to HIV patients, and it's really just looking at all comers in a 60-day period between January and April 2021. The COVID-19 positivity rate among persons living with HIV was not statistically significant. Within the trial, only 1 out of 117 patients that presented within that period was actually HIV positive. 2 patients were excluded because they presented and died within less than 24 hours. This is quite surprising. National HIV figures predict or estimate that there are approximately 32,615 persons living with HIV nationally, and within the Kingston and St. Andrew region, about 9,674 patients are known and active within the region. Within this same Kingston and St. Andrew region, there are 14,419 confirmed cases of COVID-19 since the start of the pandemic in March 2020. So given these figures and the fact that our hospital is the main hospital for this region, you would expect higher numbers of HIV patients to be presenting with COVID-19, but that has not proven to be the case. And this is quite surprising and begs the question, why is it that we're not seeing more HIV patients presenting with COVID-19? Well, there are many hypotheses, one of which is perhaps persons are really adhering to the stricter guidelines for COVID prevention. So the mask wearing, avoiding large gatherings, and sanitization protocols perhaps are being more adhered to by our HIV patients because they are very aware of the risk of COVID-19. Unfortunately, some of our patients with persons living with HIV are marginalized and may not be attending mass gatherings as much as non-HIV patients, which again would help to lower the risk of infection for these patients. But separate and apart from that, the question is, are HIV patients actually protected? And that's something of ongoing study. Now, diagnosis of COVID-19 in HIV patients does not really differ from that in non-HIV patients. It's the same process. Rapid antigen and PCR testing is done. And for the few persons who have presented with comorbid HIV COVID-19, the presentation seems to be similar. However, there have been a few cases of accelerated respiratory failure. These are patients presented with dangerously low sats, 40s, 50s, 60s on room air, marked dyspnea and exertion, and died within 24 hours. That sort of a presentation is not uncommon. They are markedly septic and in ARDS on presentation. Some of these patients I suspect are in that unknown category because they present and die so quickly, perhaps before the medical team is even able to swab the patient. So that has been a presentation that we have seen in some HIV patients, but again, the numbers are not very high. They have a presentation which is similar to most other non-HIV patients presented with COVID-19. It's the same sort of presentation, but some are presented with a PCP-like picture. So the bilateral infiltrates, marked hypoxia, and not so much coughing may also be seen, leading to confusion between the two. And because of our limited ability to test for PCP locally, PCP management tends to be empiric, particularly if the CD4 count is known and you're in that danger zone. So because COVID-19 and PCP look somewhat similar, you'll find that the management of a patient presenting with a COVID-19-like picture who is known to be HIV will tend to involve the use of cotrimoxazole. And if the patient is hypoxic, there will be the use of prednisone per PCP protocol as opposed to using dexamethasone. Renal injury is something that we noted, though it's more common in COVID-19 disease in and of itself. We're also seeing quite a bit of renal impairment in our patients with comorbid HIV and COVID-19. Now, as I mentioned, is there an interaction between the two? Now, earlier in the pandemic, it was proposed that HIV was actually protective against COVID-19. And some of the theories being proposed were that antiretroviral therapy actually helps to suppress SARS-CoV-2. It does so in vitro, and so it is presumed it does so in vivo. This has not proven to be the case for lopinavir, which is no longer part of treatment protocols. Tenofovir as well has noted to have activity against it. But also, because COVID-19 tends to be a disease which is due to a dysregulated immune response, this immune hyperactivity leading to this widespread damage. In the person with HIV, the immune system is suppressed, and therefore the response and the effect of COVID-19 is therefore suppressed. Now, these are the hypotheses. Studies have shown a little bit of both. So studies have shown that yes, there may be something there, that yes, there are less HIV patients presenting with COVID-19 and the disease is less severe. But then there are studies that show the opposite. In this study by Kanubu and Adadi, they showed a strong association between CD4 less than 200 and increased severity of disease, but the outcome didn't change. But it did say once the CD4 was below 200, there was an increased risk of progression to severe COVID-19, a 5-fold increase actually, and this was statistically significant. And what they also found was that the complications were seen in 61% of patients with CD4 count less than 200. So they definitely identified a link between severe COVID-19 disease and HIV. WHO's global clinical platform for COVID-19, due to this, gap in the literature with conflicting studies and even meta-analyses, some meta-analyses showing, yes, HIV patients do better, and others saying no, they don't. So because of this, WHO looked at surveillance data from several countries, 37 countries in fact, 24 countries reported on HIV and COVID-19, resulting in 15,522 patients with suspected or confirmed COVID-19 being evaluated. Approximately 95% of this data was from WHO Africa, and within Africa, most of the patients were from South Africa. So the data is heavily skewed towards the South African population. There was also representation from Latin America, particularly Chile. Now, what they found when they looked at the outcomes of patients who were hospitalized for COVID-19 who were in fact HIV positive, when we look at the orange box, which represents deaths, you can see that for severe critical disease versus mild to moderate disease, naturally, you have more deaths in the severe critical category, but look, you really shouldn't be having deaths in the mild to moderate category. That's not usually the case in COVID-19, so it suggests that the outcome is actually worse, that even mild to moderate patients. And you can see this figure here, 16%. 16% of patients deemed mild to moderate are actually dying. So it would suggest that, again, HIV patients actually have a worse outcome in COVID-19. So when you look at the odds ratio, HIV was seen to be an independent predictor of worse outcomes in or severe or critical presentations of COVID-19. And this statistical significance persisted even when adjusted for other coverts such as age, male gender, diabetes, and hypertension. So this is quite significant. So on that basis, what they found is that mortality was actually 23% among COVID-19 persons living with HIV, and the risk was 30% higher for severe or fatal disease in this population. Now, what was interesting, as I mentioned before, the data primarily came from South Africa. When they adjusted the data and excluded the South African data, then the statistical significance for HIV patients having a worse outcome in COVID-19, that relationship was no longer statistically significant. So it would seem that that's a South African thing. And so this is continuing investigation in this area, of course, is warranted and ongoing. Just briefly to touch on other health programs that have been affected by COVID-19. So, with COVID-19, everything that coughs is COVID-19, everything that is short of breath is COVID-19. So you have a lot of availability bias. And so certain persons with certain chronic diseases will continually get isolated. So interstitial lung disease, asthma, COPD patients, cancer patients, metastatic disease, you find that these patients tend to be isolated. So it impacts their level of care, because once they're in the isolation ward, it impacts how they can interact with the general ward population and undergo investigation. So there may be delays. So perhaps the patient really has heart failure, due to a myocardial infarction. There's going to be delays if everyone is thinking this is COVID-19. There's a diversion of resources, and particularly at a time when there's economic strain. There's definite economic strain because there's less revenue, but at the same time, more money is being spent on COVID-19 related measures. So that is, of course, going to affect other health programs. It affects our surgical list. There's less elective and non-urgent surgeries. There are treatment delays, chemotherapy delays, radiation delays. Everything is delayed because of COVID-19 related pressures on the healthcare system. And of course, the ambulatory services have to be scaled down, and there are intermittent closures because you have to divert staff to management of COVID-19 patients, particularly when the numbers are really high and bombarding the healthcare system. And that is basically it in a nutshell. Here are my references. Thank you.
Muchas gracias, doctora Nicholson Spencer.
Thank you very much, Dr. Nicholson Spencer. And now I would like to introduce Jose Ledesma. Jose Ledesma has been a technical advisor to the Ministry of Public Health in the area of HIV between 2011 and 2021, and he is currently a physician working at the infectology department of the General Hospital Plaza de la Salud, and he will talk about from HIV to COVID-19 perspective from the Dominican Republic. Welcome, Dr. Ledesma.
Welcome to the AIDS Society Fund International Symposium, the Pandemic Era's HIV Response in Latin America and the Caribbean. Today, we're going to talk from HIV to COVID-19 from the Dominican Republic perspective. In the Dominican Republic during the COVID-19 pandemic, we worked on 3 different stages to provide a response to the pandemic. We started with an emergency process in March 2020, designing and developing a ministerial guideline. In July 2020, our government responded by working with some healthcare institutions and providing financial support, as well as developing guidelines. And in February 2021, we started to consolidate processes with HIV guiding and regulatory documents, already including the situations and evidence we had gathered regarding HIV and COVID-19 co-infection. I'll discuss the emergency process that started in March 2020. Once COVID-19 was declared a pandemic in March 2020 in our country, we worked to develop a ministerial guideline that helped us develop new strategies at the community level that were user-centered and ensuring access to ARV for people living with HIV. We divided this into different times. Due to COVID-19, medicine delivery strategies were extended for many months. We had already been delivering medicines for 2 and 3 months. During this process, we were able to extend this to 6 months for eligible patients so that they would not have to come to healthcare centers to get their medicines. We designed strategies to deliver medicines at their homes and in community places for those patients who didn't want anyone to visit them at their homes. We worked on the use of technologies to follow up users through video calls, WhatsApp groups, and text messages sent to patients to stay directly in touch with them so there will be contact between healthcare services and patients. And besides, specific actions for at-risk populations were carried out, including pregnant women, older people, migrants, and key populations, so as to provide an immediate response in case of emergencies. Now, going back to normal, once the healthcare system opened up again and the economy became more dynamic, we developed general guidelines to normalize healthcare services in pandemic times. This document includes an interesting section setting forth healthcare guidelines and measures for healthcare programs with a special focus on vulnerable groups, including HIV patients, to prevent any type of stigma or discrimination towards co-infected COVID-19 patients. Finally, we also worked on the consolidation stage in February 2021. A regulatory document was developed to prevent and treat STIs, HIV, and hepatitis in the Dominican Republic. The document sets forth the guidelines to institutionalize prevention and care strategies based on users' needs and the COVID-19 pandemic. The pandemic helped us learn that promotion, prevention, care, and follow-up services supplement those services provided by the healthcare service providers network. Consequently, all these HIV COVID-19 related services should also be included in this document. It should also include any healthcare related issues that may come up during the COVID-19 pandemic. I'd like to point out that the pandemic helped us see that healthcare services may be provided outside the healthcare institutions. It helps us think of users' needs and coordinate our work with other sectors to provide an effective and sustainable response to HIV and COVID-19. I'd like to thank the Ministry of Health, UNAIDS Dominican Republic, CDC, UNAIDS, PAHO, National Health Service, GIS Consulting Company, civil society, and the network of people living with HIV with whom we have been able to work jointly to ensure improved HIV and COVID-19 services provision. Thank you very much, and I hope you have enjoyed my presentation.
Thank you, Dr. Ledesma. This has been a clear and brief presentation. Now, I would like to introduce Dr. Miguel Morales. Dr. Morales is a physician specialist and the president of the Taller Venezolano de VIH, a Venezuelan NGO that does advocacy work for the rights of people living with HIV. Today, Dr. Morales will talk about HIV prevention, treatment, and care in Venezuela. Welcome, Dr. Morales.
Buenos días, soy el doctor
Good
Miguel.
morning. I'm Dr. Miguel Morales, a specialist in infectious diseases from the Taller Venezolano de VIH, a member, a Venezuelan delegate to the Pan American Infectology Association. Today, in this symposium of the pandemic areas and HIV response in Latin America and the Caribbean, within the 20th API Congress, and with the support of the IAS Educational Fund I will talk about prevention, treatment, and care for HIV in Venezuela. In Venezuela, this information from the UNICEF report, this is from 2020, we can see there are new HIV infections in 2019, 5,200. There are no AIDS-related deaths, and according to this report, there are about 110,000 people living with HIV in the country. In the continuum of care, the 1990 and 90, as you know, we are not doing well, actually rather poorly, as compared to most of the countries in the region. 62% of the people living with HIV have an HIV diagnosis, know their status. The second 90, 64% of those patients who know their status are on antiretrovirals. And as you can see, you have no information on viral load because of the shortages we have had in the last few years. This is a zero. So 90 in Venezuela is not being achieved. We have data from the national program where we compare the last 3 years, 2018, 19, and 20. In 2018, we had 65,000 people living with HIV, and 1 year later, this number was cut by 50%, 31,000 people. So despite it hasn't been mentioned in UNAIDS reports, there are many deaths because of HIV/AIDS. There are many ARV shortages and failures. We didn't have drugs for 6 months, and many patients left the country, and that's why the number was cut by 50%. And we have the 2020 figures with 82,000 cases confirmed of HIV, according to the National HIV Program. Each of these elements was discussed in the document. Some of them have been carried out, most of them haven't, but it's important to be aware of them and to remember them because these are pending tasks. Regarding continuity of treatment, revision of treatment guidelines, I'm going to mention them later on in order to get people started on DOLU, purchase of antiretrovirals, treatment of opportunistic infections, PrEP, use of penicillin, micronutrients and related elements. They never made it to the country, and monitoring, which is done by NGO, the academia, and scientific organizations. It's important to have access to follow-up. We need CD4 count tests, resistant tests, which never made it to the country, and we should increase the capacity of our labs with gene experts so there is wider access to these tests. We don't have even one gene expert device in the country. As regards viral load tests, we got one supply, one load in 2019. These tests have been used, but they are not enough regarding access to prevention and screening tests, where we need to train the healthcare staff. We need a care algorithm. We should prevent stigma and discrimination, which are still present, and they are even worse during the pandemic. The purchase of ELISA tests and rapid HIV and syphilis tests. They are scarce in the country. We got them through some donations of UNAIDS and other organizations, but they were used in centers, important centers such as maternity hospitals, so as to prevent vertical transmission, but they are not widely available in the country. And condoms and educational materials, well, we haven't had them for 2 years now. And improvement in surveillance, we cannot improve this if there are so many weaknesses in the other areas. But again, train the healthcare staff, and epidemiologists talk about new metrics to define what has to be procured by the government, and the National Surveillance and Resistance Study and Survey, which has been stopped. Nothing has been done. We bought some tests in Mexico, but nothing happened once the pandemic started. This is a practical guideline we prepared in 2020 together with the associations, infectology associations, UNSAIDs, WHO, the Ministry of Health, etc. And somehow we defined that treatment should be started with Dolu, 3TC, tenofovir FTC, Acryptega, and the alternative was abacavir 3TC and Dolu on alone. In special cases, efavirenz was still being given, and tosonavir, but this was not available when we had a shortage for over 6 months in 2018. We didn't get any drugs, and when the donations arrived, we only got TLD co-formulated or tenofovir or abacavir 3TC, but we didn't have atazanavir nor efavirenz. Weaknesses, well, the ones you can see, there are critical roadblocks which get this crisis to continue and the problem of HIV to continue in Venezuela. There is lack of commitment to carry out the strategies and goals. It's difficult to buy ARVs for the pediatric population. We have a shortage of diagnosis tests and a shortage of reagents for viral load tests, for resistant tests, for hepatitis B, C, and TB. We haven't had PPDs for 3 or 4 months. So there are many negative elements to be considered. It's difficult to buy male and female condoms, subdermal implants, intrauterine devices. They haven't been available for 2 years. There are no treatments or tests for opportunistic infections. We don't even have tires for the trucks that carry the drugs to inland Venezuela. As you know, we also have a problem with fuel availability. So there are many issues which get these roadblocks to grow increasingly. We have the support of the PAO and UNICEF, who have given us their trucks to distribute agents and drugs, but it's always a second possibility. So there are delays in the distribution, there are issues with distribution as a whole, and this has an impact on the treatment of people living with HIV. We don't have educational campaigns. We don't have a good distribution of agents to the national network of pharmacies. It's difficult to fairly distribute and share prevention strategies. There are not enough resources to buy PrEP, we don't have it, though its use has been suggested. 6 months ago, we wrote a letter to the Ministry of Health underlying the importance of PrEP, but it hasn't been answered yet. And it's difficult to carry out basic lab tests at public hospitals because we don't have the basic elements to carry them out. And there is also a shortage in public utilities. There is no water, no power, no stuff. So this, from all points of view, from the point of view of inputs, structural, political, social points of view, make the scenario of HIV in the country a negative one. The key questions, I've already mentioned them, the key issues, I have already mentioned them, but I will summarize them. There are not enough reserves of antiretrovirals. There are interruptions in treatment for most HIV patients. There are not enough purchases or donations, so treatments have to be interrupted. We got Dolu for 6 months. After that, there were failures. There were other shortages recently. So if you don't get the complete and comprehensive treatments, it's difficult to carry out a program. The civil society is fully involved. They are always monitoring this so that we could improve or help to improve the scenario. There are no drugs for prophylaxis and treatment of opportunistic infections. There are no viral load tests. The ones we got by the end of 2019 were used in 2020, but the pandemic started and all this was interrupted. And this year, we don't have any viral load tests available. We are moving slowly here. And lab tests, well, let alone that we don't have CD4 count tests, etc. There's a limited capacity to carry out HIV tests, and we don't have condoms, lubes, and there are no educational campaigns. And these are weaknesses that we should overcome. And in conclusion, we might say that the national programs are still key to operate together with other partners and guarantee technical consistency, the distribution of products and the provision of services. Civil society organizations representing the communities that are affected and professional associations and academia play an important role in the response. The master plan in Venezuela has become a key dynamic tool to coordinate the programming and treatment of HIV, TB, and malaria, and the support and monitoring of the response. But there are still many pending issues. The important gaps in primary care should be tackled quickly. Antiretroviral treatments, opportunistic infections and drugs, laboratories, prevention tools, all these areas have been neglected and are still being neglected today. There have been no improvements, let alone nowadays. It's important to improve the flow and the exchange of information among all the participants to keep the master plan updated. Here, we need the support of many organizations, UNAIDS, WHO, organizations from the region, neighboring countries. Everybody has to contribute because we all have to move in the same directions to help one another. Our donations should be aligned with the drugs mentioned in the master plan. They should include quality products with the right shelf life. But we should all work together, as I have already said. In this world, we need global solidarity and shared responsibility. I believe this is the right motto for my presentation. And SOS Venezuela, why? Because we have problems and we need the support and assistance of all of those who, through policies, organizations, agreements, multilateral agreements and strategies, and international organizations might support us so that people living with HIV have a good quality of life with a good quality of care, the one they deserve and receive in any country in the world. Thank you very much.
We now have the opportunity to ask questions. Please send all the questions to the Q&A box. We'll try to answer as many questions as possible. If you don't have any question yet, I'll take the privilege of asking the first question. Could perhaps Omar, our friend Omar, mention specifically how the COVID pandemic has affected HIV/AIDS programs in Argentina.
Muchísimas gracias, Jane.
Thank you very much, Jean. I think the problem of COVID in HIV patients has been twofold. Direct impact, as Samantha said, there are many discussions about the real impact, but it is quite clear that people with less than 500 CD4 have a lower risk, and people with comorbidities, older people with a history of TB as well. But the largest negative impact of COVID in Argentina and in Latin America is stopping any other interventions regarding HIV programs. In Argentina, in February 2020, the PrEP program was to be launched, and as a result of COVID, the launching was delayed. It will only be launched now. Self-testing is not implemented, and PrEP should really, COVID should really leverage this attitude so that people will be able to do self-testing without having to go to the hospitals. And this is something that's not yet done in Latin America. The positive aspect is that, as we've seen in many countries, in Argentina, we are also now seeing treatments for 3 months. It's crazy to have people come to our hospitals every month. They have to spend the whole morning just to get their medicine. So as a result of COVID, we've been able to do this. But in general terms, and as my colleagues have also pointed out, the fear of HIV patients, the lack of services, has generated a reduction in the number of diagnoses, a 50% reduction. And these people are people who are not being treated, people who will come back in 2 or 3 years with an advanced disease, and we will have to provide more care. In Guatemala, for example, a study has already been published in an international journal. Death rate as a result of COVID increased by 10% in a year. This is in HIV patients, and this is because people are afraid to go to hospitals because of the COVID pandemic. And I think this is happening in the whole region. Thank you very much for your question, Jan.
Another question for our speakers. What is the level of difficulty that arose when trying to bring antiretroviral therapy directly to the homes, knowing the aspect of marginalization that people living with HIV have? Who wants to take that? Dr. Ledesma? Do you want me to repeat the question?
Yes, please.
The audience wants to know what is the level of difficulty programs have had to bring antiretroviral therapy and services to the home, considering the issue of stigma, discrimination, etc.
Doctor Ledesma, ¿quiere contestarla tú?
Dr. Ledesma, would you like to answer that question?
Creo que José no escucha bien, pero yo
I believe he cannot hear us, but well, I believe that the programs in Latin America don't consider the services they provide as proactive services. They are specifically given within the hospital context, as Pedro Kahn would say, with a Darwinian selection. Those who fight to get the treatment and the drugs get them, but the system is not concerned about the patients who haven't come to our hospitals or sites. So we don't think about it as a commitment by the sites, a commitment to keep the patients in follow-up. So there has never been an investment done to help the patients by giving them transportation facilities or whatever to come to the hospital, and let alone do they think about sending the drugs to the patients' homes. not even for those patients who are able to pay for them and are willing to pay for them. Not even in that case do hospitals in Latin America send the drugs to the patient's home. So we have to change our mindset. We have to think about quality, efficiency, so as to be able to introduce innovations. In Brazil, there are good experiences and lessons to be learned. In Rio de Janeiro, there is a program which uses home tests, so tests in the home, and the sending of PrEP to the homes, so that it is a large program, including Mexico and Peru, which doesn't include PrEP, but well, this has been done in Brazil. I believe we have to take into account this and give patients that choice. I know that some programs may not have money to send the drugs to the people's homes, but at least it should make it possible for patients who can afford to pay for them to use all these e-tools to make orders and get them delivered to their homes, to get the drugs delivered to their homes. Jose, would you like to add something here? Yes, I wanted to add something here because it's very difficult. If we already have issues in several countries in the region to get the antiretrovirals from the central depot to our hospitals around the country, it's very difficult to send them to the patients' homes. We should try and improve our follow-up and strengthen those links between the patients and the system. But I would say that it's difficult, and we should also consider stigma and discrimination, because we should be careful so as when those drugs are delivered to the homes, this shouldn't have consequences so that the people would get rejected and stigmatized by their community. So this is a difficult issue to tackle, but we should try and do this to get closer to the people living with HIV and making it easier for them to have access to treatment.
Okay, I have a quick question for Dr. Deschamps from Dr. Robert Paulino. He mentioned that in your presentation, you were monitoring patients across the border with the Dominican Republic. Any particular findings compared with the capital programs?
We found that the prevalence was higher in the capital itself than along the border, but we have to be careful because along the border, there was IOM, which was selectively identified those with symptoms and send them to us for testing. The prevalence was lower compared to the one.
A last question. Should patients with HIV/AIDS receive a third dose of vaccine, a booster dose?
Very good question, Dr. Pape. Juan Tiraboschi presented in the IAS that 75% of the patient with HIV presented antibody compared to 96% in HIV negative patient. This opened the road to think about repeating vaccination or closes booster vaccination in HIV patient, or at least measuring antibody production after that. They are looking for cellular response now, but I think it's an area of investigation, of research, and we will need to continue updating on that. Good question.
Thank you. Thank you to all the speakers. I'll be giving you some concluding remarks on this session. The COVID-19 pandemic, because of the preventive measures put in place to prevent transmission of the virus, had a negative impact on the world economy, including Latin America and the Caribbean. It also had a bad impact on other health programs. Over the past year and a half, the COVID-19 pandemic has overshadowed the 24-year-old HIV/AIDS pandemic. We just heard panelists present on the impact of COVID-19 on HIV/AIDS program in the region. Most countries experience a negative impact on HIV and TB programs, at least during the first few months of 2020. But The good news is that most have been able to recover. Now, Omar Sood from Argentina provided some grim realities for our region. 20% decrease in HIV cases worldwide, 21% increase in HIV cases in Latin America and the Caribbean. Also, a 7% increase in TB HIV deaths. He made some useful recommendations. Health workers must address stigma and discrimination. The UNU is important to eliminate stigma and discrimination. Self-testing can be helpful. Need to increase the use of PrEP in the region. Switch to regimen containing dolutegravir. Try to eliminate HIV in Latin America. To do that, we need the participation of the community, MSM, transgender women, and people living with it. Dr. Miguel Morales gives a very grim presentation of Venezuela, the many challenges faced by the IAS program even before COVID. Dr. Desma from the Dominican Republic and Marie-Desha from Haiti presented many measures to keep AIDS patients in care, provision of medicine for months, increase home care, delivery, increase the use of technology for healthcare provision. Dr. Ledesma focused on high-risk population, pregnant women, older populations, migrants, key population, and normalizing healthcare services around COVID-19. Dr. Deschamps presented on the intensification of global health services for HIV/AIDS patients, the many contribution of GESCO in the control of COVID pandemic for monitoring, surveillance, health providers training, and care. Dr. Samantha Nicholson-Spence from Jamaica raised the issue of whether HIV is a risk factor, requiring or for developing severe COVID. She mentioned the situation in Africa, mostly in South Africa, where this seems to be the case, but this seems to be less the case in other countries. In any case, this is an area of active investigation. This pandemic is far from beyond us. A long way to go until most of the world is vaccinated. How many more waves will we have in the meantime? And how many more people will die or suffer long-term complications? Thank you to our panelists for their contribution and participation in this session, especially during the special and very busy time of the year. We also would like to thank all the participants. We hope that this session was helpful to them and interesting. We hope that the information shared and discussed during this session will help you reflect on a personal and a professional level and help understand the impact of COVID-19 on the HIV epidemic in our region. We also like to thank all the participants who sent questions during this discussion and encourage you to share the recordings with your colleagues who are not able to participate with us live today. This will be available soon on the IAS Educational Fund virtual platform free of charge, and they can join the platform anytime to watch the replays, which will be available next week. Thank you all and take good care of yourself. We hope to see you later for our second session starting at 10:50 until 12:20 on combating co-infections, HIV and TB. Please connect using the link in the platform for session 2, just as you have connected for this session. We'll see you very shortly. Ciao.